Hello and good morning, everyone. This is Dr. Taha from Gastroenterology and Hepatology, and I welcome you all at this very interesting session of how and what are the problems which are really encountered in the patients with CKD and elderly population who are taking the direct oral anticoagulants and are on antiplatelet therapy in aspect of GI bleeding. So I have no disclosures for this presentation. So by the end of this session, we will be able to recognize what are the early priorities in patients presenting with GI bleeding, how to stratify and identify the patients who are at high risk and require the urgent intervention, and how to manage the patients with GI bleed on direct and oral anticoagulants and antiplatelet therapy. Because CKD, the chronic kidney disease, it's a double-edged sword, and it's also not only it increases the risk of bleeding, but it also increases the risk of thrombosis. We will look into it why and how. Now, the last thing we will discuss regarding the timing of endoscopy in the patients presenting with GI bleeding, especially in the CKD population. So why this topic matters basically? So GI bleeding remains a common cause of emergency admission and urgent endoscopy in patients presenting to the hospital. And it's a commonly encountered problem in the endoscopy suite to the ICU doctors, to the ER doctors. With the advent of direct oral anticoagulants and the antiplatelet therapies, this problem has been worsened, and it has been due to the increasing incidence of atrial fibrillation, venous thromboembolism, coronary artery disease, and in the patients who have recently undergone coronary stent placements. And this risk of GI bleeding has been enhanced by the presence of the chronic kidney disease and in the elderly frail population. So the challenge is not only to stop the bleeding, but also to prevent the stroke, further episodes of stroke, stent thrombosis, renal decompensation, or procedural delay. So it should be a multidisciplinary team involvement involving the ER doctor, involving the gastroenterologist, involving the hematologist, even involving the nephrologist and the cardiologist. So upper GI bleeding usually has higher early mortality than the lower GI bleeding. Why? Because upper GI bleeding can cause hypotension, hemodynamic instability. Lower GI bleed usually rarely causes the hemodynamic instability. However, these factors are worsened by the presence of the comorbidities like CKD in frail patients and those having the cardiovascular risk factors. So, and further worsened by the direct oral anticoagulants and antiplatelet therapies. They both complicate the management in these patients. So, the care is directed towards the early stabilization and the coordinated care involving again the multidisciplinary team. So the challenge is not only to control the bleeding, but balancing rebleeding risk with the thrombosis risk, especially in the CKD population. So in general, what are the common causes of the GI bleeding? The upper GI bleed. First, the peptic ulcer disease. You have the gastric and the duodenal ulcers. The Forest classification is used for it. We will look into it later on. Then you have the erosive esophagitis or duodenitis. There might be in the patient with chronic liver disease, they might be having the variceal bleeding. Yeah. So in the common causes of the lower GI bleeding in the patients include the diverticular bleeding, which is the one of the most common causes of large volume painless bleeding, angiodysplasias, and the others. So how this differs, the GI bleeding, how it differs in the CKD and elderly patients, and why they need the urgent interventions. Because in CKD population, most of the direct oral anticoagulants, they have the clearance through the renal area. They have the renal elimination route. So in CKD population, the kidney function is compromised. There is increased drug accumulation. Secondly, in the CKD population, the uremia, it causes the platelet dysfunction that again increases the bleeding tendency. And the CKD population, they are at risk of higher volume overload during resuscitation. And in CKD population, the angiodysplasias, which are the fragile ectatic blood vessels, which we'll be looking at later on. So these are the causes of not only one-time bleeding, but they are the causes of the recurrent bleeding. And in this CKD population, it should involve a multidisciplinary team involvement, in especially the nephrologist. Now, in the elderly population, elderly patients, they are usually frail and they are on multiple medications, especially the blood thinners. And in these patients, early identification of the shock is it's very difficult because their physiological reserve is low. And again, they are also at higher risk of sedation and aspiration. And delirium and functional decline also persist after the acute illness. So why in CKD we have this GI bleeding? So CKD causes increase in the uremic toxins that leads to chronic inflammation, oxidative stress, hypoxia, anemia, and endothelial dysfunction. This endothelial dysfunction then causes dysregulated angiogenesis and impaired hemostasis, which causes the formation of the fragile ectatic blood vessels, especially in the small bowel. So this is called as angiodysplasia. And secondly, the platelet dysfunction is there. So these all factors, it's a multi-factorial thing. So there is high risk of GI bleeding in these patients. So how CKD leads to angiodysplasia and GI bleeding? Again, the uremic toxins, inflammation leading to the endothelial injury, and causing the release of the vascular endothelial growth factors, and there will be poor vessel maturation, and then there will be the formation of AV malformations, and that causes the GI bleeding. So again, it's the abdominal vessels, abdominal platelets, and high risk of antithrombotic or direct oral anticoagulants or antiplatelet therapies that are involved in causing the CKD-related GI bleeding. So what are the common causes of GI bleeding in CKD? Most of them are same. Apart from that, in these patients, angiodysplasias in the small bowel are quite frequent. And they are the cause of not only one-time bleeding, but also the recurrent bleeding. So in elderly patients, dialysis dependent, and having the valvular heart disease and on antiplatelet or direct oral anticoagulants and recurrent unexplained anemia, think of Heidi's syndrome or angiodysplasias. Heidi's syndrome is basically a syndrome in which we have a valvular heart disease along with AV malformations in the gut. So how to approach? If a patient presents with CKD-related GI bleeding, first of all, identify it. Maintain the airway breathing circulation. IV access, send the labs, send the cross match, and check the hemodynamics of the patient. Then the drug history in the CKD history is very important. There are 4 questions which we ask in the drug history. What drugs are you taking? What is the dosage of the drug you are taking? When was the last drug you took? And how many days in the week or in a month you undergo the hemodialysis? And during hemodialysis, do you receive any anticoagulant like heparin? Then you localize the source either through the endoscopy, colonoscopy, or if the patient is hemodynamically unstable, you should call the interventional radiology, and the patient should undergo the CT angiography. Then how to treat it? There are certain endoscopic methods. Then there are the basic method is the best thing is to manage the antithrombotic as well. So in this case, you have to involve the cardiology team as well to correct the anemia, and again the multidisciplinary team involvement. So CKD creates a paradoxical hemostatic state, increasing the thrombosis risk and the bleeding risk simultaneously. So this is why a simple instruction like stop anticoagulation is often unsafe unless we also define when and how to restart it. So what is the best direct oral anticoagulant? As I discussed earlier, that most of them are eliminated through the renal route. So the most safest of all of them is apixaban because it has a lower renal clearance and is often the best supported direct oral anticoagulant in the advanced CKD. However, dabigatran is having the highest renal elimination, and it's the most vulnerable to accumulate. So, in this is a slide which shows that if the patient is with having anemia, CKD, or prior GI bleeding, this is a forest plot showing that GI bleeding, when apixaban is compared with the other direct oral anticoagulants, the GI bleeding is reduced significantly in the patients taking apixaban. However, the stroke risk was not reduced in any of these drugs when compared end to end. Now, do the antiplatelets matter? In the CKD patients, in the patient with coronary artery disease, in those with atrial fibrillation or ischemic heart disease, if the patient is on direct oral anticoagulant and the antiplatelet therapy is added, it may worsen the complications, right? So again, it's like a time bomb. And the bleeding rates, if the patient is on apixaban, as I discussed earlier, that GI bleeding is less. But apixaban plus any antiplatelet therapy like aspirin or Plavix, the risk again becomes similar to that of the other oral anticoagulants. Now, when the direct oral anticoagulants were compared with the vitamin K antagonist like warfarin in atrial fibrillation or CKD patients, so you can see here that direct or oral anticoagulants, the rates of GI bleeding are not significantly reduced. So direct oral anticoagulants are good in CKD, but it should be used with caution. So in ESRD population, usually unfractionated heparin is given during the dialysis because of its low half-life. However, the low molecular weight heparin, it may accumulate in the CKD patients, stage 4 or 5, and may need dose adjustment or anti-factor 10A monitoring. So warfarin requires careful INR monitoring. The safest plan is in the patients with CKD presenting with GI bleeding is individualized, and we should look at what is the indication of giving the direct oral anticoagulants, what is the thrombotic risk, what is the bleeding source, either it is controlled or not. What is the renal clearance right now? The patient is either CKD, chronic kidney disease 2 or 3, or it's like he's on maintenance hemodialysis, and whether the patient is frail or not. So this is ACC bleeding pathway for GI bleeding on oral anticoagulants. So first, assess the hemodynamic instability, whether the patient is stable or not. When is to transfuse? This is the main important point. If the hemoglobin drop is greater than 2 grams per deciliter, or if the patient is having comorbidities with the hemoglobin of less than 8, then you have to transfuse. And if the patient usually reserve the transfusion of the packed cell until there is massive GI bleed. And hold and identify. Again, the drug history is very important. In the first 5 minutes of the patient's presentation, if the patient is hemodynamically stable, you can ask the patient, or if the patient is hemodynamically unstable, you can ask the attendant what drug he's taking, when was the last dose received, what is the current dose, and what is the renal function, and I mean like how many times in a week he undergoes the hemodialysis. So how to control the bleeding? There are endoscopic methods, there is interventional radiology or the CT angiography, which is reserved for the patients who are of small bowel bleed or those who are hemodynamically unstable. So now there is antidote for some of the medications like warfarin. You give prothrombin complex concentrate plus vitamin K. For dabigatran, it's idrasozumab. And the other direct oral anticoagulants, we use the Nexent alpha. Now the main basic question is when to restart. Suppose if the patient is on atrial fibrillation, having ischemic heart disease, undergone the coronary stent placement, when to restart these medications. So these factors are only be solved by the involvement of the multidisciplinary team. So we have discussed this, that in the first hour you assess the patient is stable or unstable. If unstable, you give fluids, you give blood, you consider massive transfusion, and you urgently call your interventional radiology colleague or to perform the CT angiography or to embolize that vessel. Now, if the patient is stable, if the patient is having upper GI bleed, then you start the patient. If it's non-varicose upper GI bleed, suppose, so you start, which is the most of the, which is the one of the most common causes of GI bleed in CKD population. So you start the patient on IV Rizec infusion first by giving the 80 milligram stat IV Rizec followed by the 8 milligram per hour, and then you plan the endoscopy and colonoscopy. So what are the red flags we should be worried about? Systolic blood pressure less than 100, heart rate greater than 100, syncope, ongoing hematemesis, rapid hemoglobin drop, and lactate elevation. So these are the certain scores which is normally used to stratify the patients whether to perform the urgent endoscopic intervention or not. So these scores are Glasgow Blatchford score, AM65 score, Rockall score. Now, transfusion and antithrombotic reversal. So as we discussed, for warfarin, you hold the drug and you if the INR is greater than 5, or if the patient presents with bleeding, like in this case, you give factor 4 prothrombin complex and with vitamin K. In direct oral anticoagulants case, for dabigatran, you give idracizumab. For apixaban and rivaroxaban, you give adnexanet alpha for life-threatening uncontrolled bleed. And you can also use the factor 4 prothrombin complex concentrate if the adnexanet alpha is not available. Antiplatelet therapy, you have to, if the patient is taking aspirin after he's having the coronary stent placement, that is secondary prophylaxis. So you have to resume it as soon as possible once the hemostasis is achieved. However, the other like Plavix, you can involve the cardiologist, and so that it should be a combined decision. Usually, it is once the hemostasis is achieved, it is usually resumed after 5 to 7 days. So now, when and how to scope? Usually in upper GI endoscopy, because the patient might develop the hemodynamic instability. So the endoscopy should be performed in 24 hours usually, but preferably within the 6 to 8 hours. And what you have to look forward to, if the patient is having any high risk ulcer, or in the patient with coexisting CLD, the patient might be having the varicose bleeding. In the lower GI bleed, you have to resuscitate the first, and you have to, if the patient is if the patient is having hematochezia, that is the bleeding per rectum, and the patient is having hemodynamic instability, first do the upper GI endoscopy to rule out the upper GI cause, because the blood itself is purgative. It causes the contractility, and it quickly reaches the rectum and the colon, and then that can, if you will miss it, that can be more problematic. So then colonoscopy should be performed after stabilization and bowel preparation, and CT angiography first if ongoing brisk bleeding or instability. So what are the pharmacological therapies? We discuss that in non-varicose upper GI bleeding, which is the ulcer bleeding, we usually start with IV PPI therapy, and in varicose bleeding, we use the somatostatin analogs like octreotide or terlipressin. We give the prophylactic antibiotic, and then we do the varicose band ligation. In lower GI bleeding, no PPI role, and resuscitate the patient first. Do the colonoscopy. If you do not find any lesion up to the terminal ileum, go for the CT angiography and call your IR. So this is in the upper GI bleeding, this is the Forrest classification of the peptic ulcer. You can see 1A is called as active spurting. And you can, in the black, which is written there, the rebleeding risk is almost 60 to 100%. So there are certain, why this classification was made, because to stratify which patients need the dual therapy or a single therapy. Dual therapy means if we see the ulcer, we just inject the adrenaline in 4 quadrants around the ulcer, then we clip the blood vessel. And in 1B, it's just oozing. So you don't have the any punctum or any site to localize. So in that case, most of the cases are managed by the adrenaline injection. In the 2A non-bleeding blood vessel, you also clip inject the adrenaline around the blood vessel, and then you clip it. In the adherent clot 2B, it might be misguiding. 2B, it might be misguiding. So you have to shave the clot, see the underlying vessel, and then you have to decide accordingly. The clean-based ulcers or the flat spot in ulcer base, these two classifications like 2C and 3, they are managed by the PPI therapy. And after managing these ulcers with clipping with the dual therapy, you have to keep these patients on the Ryzek infusion for next 72 hours. Okay, second look endoscopy, when to perform it. If the patient's hemoglobin is not rising, if the patient is still hemodynamically unstable, if the patient's vitals are not going up, then you have to do the second look endoscopy. So these are all hemostasis options, which include the injection therapy, the clipping, band ligation for the varicose bleed, hemostatic powders, thermal therapies like APCs or bipolar, which we use in the GAVE pattern, which usually seen in the gastric antrum. So, what are the predictors of the mortality in end-stage renal disease patient present with the upper GI bleed? So, we saw that the patient having diabetes, hypotension at the time of presentation, tachycardia, Forest class 1A ulcer, increased INR, decreased platelets, and administration of the requiring administration of dual therapies on endoscopy, like both the clipping and also the epinephrine injection. So these are the factors that were responsible for the increased mortality in patients with lower upper GI bleeding. Now, lower GI bleeding, if the patient presents with acute hematochezia, so if the patient is unstable, resuscitate, call the IR team, and then embolize, ask them to embolize, request them to embolize the vessel if they found any, and if they still cannot identify the source, go for surgery. And if the patient is stable, then exclude the upper GI source, bowel preparation, colonoscopy, and then if still not able to locate the lesion, so you have to plan for ask the IR team or the surgical team. Now the main question: when to resume it? Aspirin, if it's taken after the after the coronary stent placement, so you have to resume it early, ideally within the same day or within 24 hours once hemostasis is secured. For Plavix, it is usually said that it can be resumed after 5 to 7 days, but please involve the cardiology colleagues. In direct oral anticoagulants, restart when the patient is stable and the bleeding risk is acceptable. And many high thrombotic risk patients are restarted within 3 to 7 days. So always document what is the indication of these medications, and was the lesion treated or not, what is the current renal function, when was the last dose of direct oral anticoagulants or antiplatelet therapy was received, and when we should resume it. Now we will be discussing some cases. So 82-year-old woman with CKD stage 4, atrial fibrillation, currently on apixaban, presents with melena, dizziness, and hemoglobin of 7.6. First, you have to stabilize the patient. Again, the drug history is very important. Third, you have to treat early. You have to, because 82 years will not give you much time. So you have to give the patient the PPI therapy and consider reversal only if life-threatening or uncontrolled bleeding. And then you have to do the endoscopy after stabilization, identify the lesion and treat it. And when to resume it, again, ask the cardiologist colleagues. Because CKD can prolong the direct oral anticoagulant effect and increase both the bleeding risk and the procedural complexity. Now, 79-year-old man on hemodialysis, and he is having the ischemic heart disease in the form of coronary artery disease, and he is not on any anticoagulant. He is on dual antiplatelet therapy, which is aspirin and clopidogrel. So again, after stabilizing, ask the patients that what medication he is taking, then suspect angiodysplasia or diverticular bleed, which is very common in the patients taking the antiplatelet therapy, and confirm what is the when was the last dialysis done. Okay, then you have to stabilize it through endoscopy or colonoscopy. But in this case, the patient presented with large volume hematochezia. So it's better to perform the CT angiography first. If stable, then if the patient is stable, then you can go for bowel preparation and followed by the colonoscopy. And when to resume it? Aspirin as soon as possible, the hemostasis is achieved for secondary prevention. For clopidogrel, ask the cardiologist. This is the last case, 85-year-old man with CKD stage 3B, atrial fibrillation on warfarin, presents with melena and has increased INR. So in this case, you have to be holding the warfarin, and for major bleed, you have to give factor 4 prothrombin complex concentrate and vitamin K as an antidote. And then you have to perform the endoscopy within 24 hours after stabilization and perform hemostasis if required. And you have to restart considering the risk and the benefits in this patient. So if a patient presents with frail patient presents with CKD4 and atrial fibrillation on apixaban represents 48 hours after ulcer clipping with recurrent melena and falling hemoglobin. In this patient, you have to review the first bleed. Go and look into the endoscopy, which was the intervention done, where was the lesion, how it was treated, when was the last anticoagulant used, what was the renal function, and then you have to hold the anticoagulant, give the high dose PPI, and plan repeat endoscopy for suspected rebleeding. And in this patient, you can consider over the scope clips, topical agents, and then if not controlled bleeding, you can use the CTA or IR help. And there are certain factors that causes the recurrence, especially in the frail and elderly population. These are H. pylori, and you have to avoid the NSAIDs and restart the anticoagulation later with a documented plan and asking the cardiologist. So what is the take-home message in these patients? You have to first stabilize the patient. Scope is the second option. Now, know the drug, what's the dose, what was the last dose, and the renal function. And the transfusion should only be restricted to the patients with massive upper GI bleeding. And in most of the upper GI bleed, upper GI endoscopy should be performed preferably within the 6 hours or within at least 24 hours. And if unstable, CT angiography or interventional radiology. Please consider the comorbidities like CKD and elderly patients, because they need gentler, faster resuscitation and more medication review. And then finally restart the antithrombotics, antiplatelets, anticoagulants by involving the multidisciplinary team. These are my references. Thank you.